Welcome to tonight's Healthy Kids for Professionals, Managing Children Who Are Above a Healthy Weight webinar. We're joined tonight by our presenters, Dr. Shirley Alexander and Dr. Kean-Seng Lim. So they will be presenting the webinar tonight and answering your questions as they come through as well. So Dr. Kean-Seng Lim is a general practitioner at Mount Druitt Medical Centre. He's also the Vice President of the Australian Medical Association in New South Wales. Dr. Shirley Alexander is a staff specialist paediatrician at Children's Hospital at Westmead. She's also head of Children's Hospital Institute of Sports Medicine and Weight Management Services. So before we get started, I would just like to do an acknowledgement of country. So we would like to recognise the traditional custodians of the land and sea on which we live and work. Alrighty, well that's about it. I think we're ready to get started. I will hand over to Dr. Lim now to talk you through an overview of this webinar.
So welcome to this webinar, fellow general practitioners and doctors. So firstly, an overview of this webinar. This webinar's, first of all, Shirley will talk about a summary of the previous webinar, which was raising the issue and addressing some of the questions raised there. Then we'll talk about how we assist and arrange as per the Ask, Assess, Assist and Arrange process for managing children who are above a healthy weight. And then we'll go through some difficult scenarios. By the end of this online activity, we should be meeting the following objectives. So ideally, we should be in a position to be able to discuss and feel confident with discussing weight with children and families using appropriate and non-stigmatizing language, provide appropriate advice about family-focused healthy behaviors, to have an awareness of and discuss the existing support programs and services that are available to children and families, and specifically also being aware and know how to utilize the Go for Fun program for or to which we can refer children who are above a healthy weight. So I'm going to pass over to Shirley now to give us a brief summary of Webinar 1 and a bit more about obesity.
Thank you, Ken. So welcome everybody. It's great to have so many people online and come back again. So I'm going to give a short summary of what we did in the webinar with Georgia last month, I think it was. And just to say that the first webinar actually was recorded and it will be available for viewing on the RACGP website in a couple of weeks' time. So rather than potentially posing additional questions for that at the moment, it might be worthwhile having a look at that first, and then you could maybe, if you want to, email some questions at to the email addresses that you got the last time. So just to recap, in the last webinar we highlighted that it is now really recognised that children with overweight and obesity, or children above and severely above a healthy weight range, is a major issue, so much so that it is one of the few, well, it's the only childhood condition of the 12 Premier's priorities. And one of the reasons for this is that it's one of the most common chronic diseases in childhood. 1 in 4 school-aged children have overweight or obesity, and although, as you can see from the slide here, it looks like the prevalence is actually beginning to plateau out a little bit, which is great, means that some of the changes that we've been making have started to make a difference. But I'd like to just point out that it still is 1 in 4 children with weight issues, or above a healthy weight. And not only that, the worrying trend is that the prevalence of obesity, and particularly severe obesity, is actually continuing to increase. So lots of work being done, more work needs to be done, and just to also be aware that there are some pockets of children that have even higher risk and higher prevalence of obesity than the general population, those being from a lower socioeconomic background, and also those from certain ethnic backgrounds, particularly from the Middle East. Okay, so actually, sorry, go back. Just to address some of the questions that were asked in the last webinar. And also just to cover that one of the issues that we talked about in the previous one is that there's a problem with recognising children with overweight or obesity above a healthy weight, and particularly parents that have weight issues themselves. So one of the questions that was asked was the heritability of obesity is said to be about 40 to 80%. What are the relatively common conditions we should be thinking about in general practice? At the end of the day, childhood obesity is somewhat different from adult obesity. Many of adults with obesity have underlying medical conditions that have either caused the obesity or significantly contributed to the obesity. This is much less so the case in childhood. Ultimately, it's only relatively about 5% of children that have a pure genetic disorder that has a propensity for obesity, or a pure medical condition that has caused their obesity. So it's basically remembering that the environment is the main problem, and that's what we need to address. And as I said then, it's the genes, or the epigenetic changes, if you like, is like the gun, but it's the environment that's like the trigger that actually sparks off the excessive weight gain. So we covered that sort of leads into that. We covered that excess weight gain, or having a weight status above the healthy weight, it can affect any system in the body, and what we find. So as GPs, you know what excessive adipose tissue problems that can occur, and it's the same in children. Diabetes, benign intracranial hypertension is something that actually we're seeing even more of in our clinic. Problems with fatty liver disease, etc. But one of the potential differences, I think, in childhood obesity and adult obesity is that the children don't always present because of concerns about obesity, but more because there are problems with bullying or teasing at school, so parents are worried about that. Sometimes there might be low self-esteem, there might be school avoidance because of issues around that. And so the reason for presentation in most of the children that you'll see that have weight above the healthy range will be for something totally different, but actually might be exacerbated because of the weights, such as a chest or asthma problem. So in recognition that childhood obesity is a significant issue, there's been a lot of work, particularly in New South Wales, and as I said, it's a Premier's priority. It's one of 12. It's the only childhood priority, and New South Wales Health have been, or the Ministry of Health have been working in a number of areas, including the clinical side, across all spectrums, primary, secondary and tertiary care levels. They're also working with schools, they're working in preschool and childhood settings, and they're working in the food and built environment. And one of the questions from the last webinar is there anything schools currently do or can do? And yes, there are lots of things that school can do. Many of the schools follow the the traffic light system for healthier canteens. Many of them do crunch and sip to encourage children to drink water and have fruit and vegetables. Not all schools do it, but there are a large percentage. And personally, I would like to see the schools doing a lot more about physical activity and interaction for that, because we know that physical activity is actually good for a number of things. So the fact that New South Wales Health and the Ministry of Health have been working on multiple areas just highlights that obesity is a complex condition. It's multifactorial, and there's not one single solution. It has to be a suite of solutions, and that's what we've been working towards. And in fact, we've been working with the Ministry of Health on a regular basis to help develop a number of resources and things that we'll talk about later.
So I suppose this is one of those things where, as general practitioners, where there are limits to what we can do, but there's also things that we can do. As Shirley's pointed out, there is a very large social, ecological component to obesity, and especially how we manage it at a systems-based level. So we have to look at it as a whole of system area, and the things that we can do as general practitioners are interesting because we can use this as one of the tools to become engaged at community levels, but there is, of course, still the patient we have to see in front of us. So one of the interesting things is that New South Wales Health have been engaging much more closely with general practice in trying to address this issue. And there are some very strong reasons for it. If we follow the model of general practice, where general practice is continuous, comprehensive, family-based, community-based, seeing patients for their lifetime in the context of the social milieu with their whole family, these all provide a great starting point. So there's often that background knowledge which assists in knowing how to address each patient or each child and their family. Because addressing the issue of child weight is not just an issue of dealing with the child, but it's actually addressing the whole environment. The continuity of care is a vital part because any program, no matter how good it is a time-limited program. And so whatever else happens needs to continue on beyond the length of that program. And we know that for children, and in fact we know that 86% of the population have at least one contact with a general practitioner each year. So this is part of the work of general practice, which is managing these complex and chronic conditions and that interplay with different conditions.
So what we also covered in the first webinar was how to raise the issue, because that we all know obesity is a very sensitive issue, and it's often difficult for people to broach it. Although we use the medical term obesity and overweight, the New South Wales Health have been doing a lot of work around what sort of language to use, because at the end of the day, it is about communication. It's about using sensitive language that is not stigmatising, and so helps to engage and progress discussions around weight. And so what we encourage people to do is to talk about things in terms of below a healthy weight, above a healthy weight, or well above a healthy weight when you're speaking with families in particular, because people often find using the word obesity a bit more offensive. So we like to use that language. We like to do the heights and weights to make it normalised, to put it on a BMI chart and then show the chart as an introduction for the parents to say, look, you know, I can see your child is above a healthy weight. Is that something that you've thought about before? If not, you know, maybe that's something that we could discuss. I know you haven't come this time to discuss that, but maybe we could make an appointment to discuss in detail another time. So around that sort of thing, one of the other questions that we got last time was, what about children under the age of 2? How is above a healthy weight determined in this age group, and at what point is intervention required for this age group? So again, I would say you're looking at weight for age, and again, once you're above the 97th centile, you really are beginning to get into that above a healthy weight category. We don't work with BMI in the same way in the under 2s, and I think overall the focus again should be not necessarily you know, sort of obesity per se, but looking at healthy feeding practices with the parents and teaching them. What we normally do is get the families to talk to the early childhood nurses and go over exactly how they're, you know, what they're feeding the children, how much milk they're giving them. You know, by the age of 3, they really shouldn't be having a nighttime bottle, that sort of thing. So it's you know, so it's being again sensitive, not blaming the parents, because many parents, they might be first-time parents, are working within the knowledge that they've got, but it's just teaching them or helping them to develop strategies for healthy eating. And 2 other last questions on that was, how can an overweight GP discuss a child's weight? And if a mum's overweight, then she'll be protective and her guard will be up. Well, the first thing I would say, even if you have a weight issue, excess weight issue yourself as a GP, it shouldn't deter you from bringing it up. It's like if you have hypertension, it's not going to stop you talking about hypertension in your patients. And I would just say, so sometimes when I'm talking to families, I'm talking about good sleeping practices, for example, and I say to them, you know, I'm actually not the best at that. I don't always get to bed, you know, at the right time. And so whenever I'm talking to people about that, it's a reminder for myself that I need to make some changes to have a healthier lifestyle. And again, even if your parent has weight issues, you know, it's talking in general terms of health, not weight per se, and doing these things for the whole family to get healthier. So take-home messages from the last time was basically make it routine, so it's not it's not strange for height and weight to be done when children come to see you. Using sensitive, non-stigmatising language so that they're more open and more likely to engage. Use BMI charts to show families where the weight of the BMI or the BMI status of the child is, so that you can lead into talking about it, and talking in terms of health and as family-wide practices for healthy habits and around nutrition and activity.
So this next section of the webinar is about assessing and managing children who are above a healthy weight, with a particular focus on the resources which are available through New South Wales Health, and a lot of these are available online, and particularly how we can actually use this in general practice. So, I mean, one of the key things, first of all, is that assessment, and that's part of what we'll talk about, which is what tools are available, how we can use those, and in fact, not even necessarily just as general practitioners, but how our practice team can use it. So whether that be the practice nurse or the medical assistant, the dietitian within the practice, and how this can all be done in using the same language and with consistency. So the first thing is to talk about this approach. So the 4A's approach is very much in alignment with the sort of approach that we have for managing adult obesity, and also in fact for managing most other conditions where we are discussing issues with patients. So the 4A's, of course, being ask and assess, advise, assist, and arrange. And so this flowchart is available and is downloadable from the pro.healthykids.newsouthwales.gov.au website. And it's a very logical way and a very streamlined process which will be able to be followed by any member in the practice team. So it provides a good workflow.
So I'd just like to add there that this flow chart or pathway came after a lot of discussion with a number of people from a number of health disciplines to sort of agree on what we felt would be the best as a generic health pathway. So a lot of work went into that, so hopefully it makes sense to everybody.
So certainly, I mean, to follow on from that, at our practice, this is a sort of chart or pathway that gets put in at a few different levels. There's actually a copy at the front desk. There's also a copy at the nurse's station, and of course the doctors have it available to them. Part of the idea is that everyone is able to be on the same page, and so the whole practice team has an awareness of the sort of workflow that we are going to follow. So it's a logical arrangement going through a process. As with any practice, it's something which a practice is free to customize if need be. But it also aligns very well with the resources available at the pro.healthykids.newsouthwales.gov.au website. And so the website has been designed in a manner which makes it accessible and usable as a tool by any person in the practice. So this is what the practice website looks like. And I don't know, what the website looks like at the New South Wales Health end, and I don't know whether anyone's had a chance to look at it or use it yet. However, to give you an example about how this works at our practice level, this is something which scales very well to the iPads, and in our should probably not be using the word iPad, I should use tablet. So it scales very well to tablets, and in our practice, the practice nurse is able to use this on a tablet to talk to patients, children and their families as needed about the process that we go through. So it's set out in a similar sort of manner, that assess, advise, assist and arrange. Now, this website is free and open to anyone, and that actually means that we can allow other practitioners, whether they be health practitioners, or in fact we can allow our patients access to it as well, because there are still some very useful Q&As, some very useful video resources, and a very handy lot of downloadable resources on it. So we'll be talking about how some of these resources fit into our day-to-day workflow. Now, the clinical resources there have these sort of points or have these aims in mind. So firstly, it's about engaging families and raising that issue. So this is something which can cause a lot of angst amongst health professionals. Issues which Shirley has raised in some of the previous questions. How do we raise this? What if we have some pushback? Could there be some friction? Could there be issues if, say, the doctor, him or herself, is not within a healthy weight range? And what if the family are sensitive about that issue? How can we address these? And on the website, there are quite a few Q&As, especially in the advice section, which talk about how these issues could be dealt with. The clinical resources also explain in a very neutral manner about how overweight and obesity is setting expectations and framing the issue as a health problem. And it assists the patient to set goals and, of course, guide both the patient and family as well as the doctors in terms of setting and guiding their ongoing management. So there was a question earlier on about the BMI charts. And so the BMI charts are available either as a downloadable sheet on this website, or actually within the website itself. If you were to click on the Assess button, you'd be able to either download that BMI chart or go to the Healthy BMI Calculator, which then plots a patient's weight or a child's weight on this chart here. So in this example, you can see a girl's 2 to 18 BMI chart showing what the percentile band that a person's BMI falls within. So are they within the healthy 5 to 85% band, or are they above? Bearing in mind, of course, as we all know, that the BMI is not a 20 to 25 for normal weight for children. And that BMI range is going to change according to the age of the child. So by plotting it on this chart, you can do two things. One of them is actually demonstrate to a patient and their family, and it's actually more the family a lot of the time, where they stand on the chart. And I find one very useful way of using this chart is actually, after plotting it, is just turning the screen around to a patient, or if I'm using a tablet, to actually show the tablet to the patient and say, well, this is where you stand, you know, this is the red zone, this is the orange zone, this is the green zone, and this is where you are. And then perhaps let the patient and their family come to some sort of thought about what to raise the question and to ask the next question about where to from here. So the next part of the other elements of this website are the conversation starters. So the conversation starters can be found in this advise part, and it raises a few, well, it's got a few commonly asked questions, so FAQs. And the FAQs are often those ones which have actually been raised already by some other participants in this webinar, such as, how do I raise this question? What do I do if I am not within a healthy weight range myself? How do I do this if I'm not confident? How do I do this if I don't have, if there is some pushback from the family? So part of this is part of where we as general practitioners have a little bit more of an advantage is often having that familiarity with patients, familiarity with their family, and knowing where to push, knowing how hard to push sometimes, and knowing when to do it. Because sometimes it's a case of finding the right time. And as Shirley says, sometimes it's best not to deal with it at that point, but perhaps to say, let's come back to that question after. So this is where I think there's been a few discussion points raised. And there have been some questions which have been raised by participants in previous webinars. And this is about that approach to assessment and management. So if you like, this is actually going right back to that first of the 4 A's, which is the ask and assess part. And so there were some questions here from the audience in the last webinar, and I'm going to sort of raise some of those, and I think that Shirley and I will probably both try to answer them. So one of the questions was, how do you treat younger children, especially those under 2 years of age?
So, so as I said previously, what we prefer to do is to more redirect to the early childhood nurse, because hopefully these parents have had some connection with the childhood nurse in the earlier days when they were establishing feeding, and get some advice from the nurse about healthier feeding practices. It's not good to be having a huge amount of milk by in the 1 to 2 year olds, for example. You want to have the child to be starting to have the same sort of food as the parents, and developing good eating habits like sitting at the table with the family, with the screen off. So it's the emphasis is not necessarily on the weight per se, but on more healthy practices that need to be established at an early age, because it's often if you can get those healthier eating, in particular eating habits, started at an early age, they're more likely to persist in the rest of their childhood and into adulthood.
So the next question, which always comes up, is can we use a GP management plan, and I'm assuming this refers to the team care arrangements as well, to refer obese or children above or well above a healthy weight range to dietitians / exercise physiologists / other services? And this one is always a complicated question. Probably the best way to look at this is to actually go back to the Medicare descriptors of where a GP management plan and team care arrangements can be used, which is basically that they are available for use where there is a chronic complex condition. And the definition of complex condition is almost circular, because it's almost a case of a complex condition is defined as any condition which is going to last more than 6 months and requires the care of a multidisciplinary team. But we're sort of stuck on this one, given that obesity has not and is not currently recognized as a disease as such in Australia. And so if obesity is the only problem that someone suffers from, then it would probably be difficult to justify using a team care arrangement and management plan for that patient. However, if obesity were a component of or a comorbid factor, then there might be the capacity to use it. So an example might be a child with obstructive sleep apnea who also has obesity, in which case then I think it is likely that a GP management plan and team care arrangement could be used in that case. However, if you had a well child who had no other complications, then it's probably unlikely obesity could be used. Other situations where it might be able to be used would be where there might be psychological factors, bullying at school, school refusal, other complex issues which were to come into it. The problem is that Medicare and the department does not give us very much guidance on this, and tends to actually say it is up to the judgment of each practitioner to do so. However, there is a footnote somewhere in the very, very fine print of Medicare descriptors saying that obesity itself is not generally recognized as a disease state for which management plans and team care arrangements can be used. So does it help us? I'm not sure, but this is the way it stands, and we have to work within the rules.
So one of the other questions was, do you ever use medications in kids? And I presume for treating the obesity. And the short answer is very rarely. The long answer is the short answer is there are very few that are actually registered to be used with children with obesity, which is 0. Orlistat is sometimes used in adolescents above the age of 12, but the side effects are usually very poorly tolerated, and so they tend not to be adherent to taking it. Occasionally we'll use metformin, and I think that will be something that we can talk about a little bit later. In other ones, we use metformin for, obviously, if they have developed type 2 diabetes, but we will also use it in certain situations of insulin resistance. But for me, usually I go with lifestyle change first, even if they have quite marked insulin resistance. And if that starts to fail, then I might consider adding in metformin, particularly if they have very severe obesity or a very strong family genetic history of type 2 diabetes, for example. One of the other questions was, should we be looking at weight loss in overweight kids or maintenance of weight that they can grow into as they get taller? And I would say yes. In children that have overweight or just above the healthy weight range, certainly you wouldn't really be looking at weight loss. The only time we would say looking at weight loss is when they have a weight range of well above the healthy weight range, or if they have complications secondary to their obesity. So for the majority of patients that you see, it would be looking at either slowing down the rate of weight gain or being weight maintenance and allowing that growth to occur, to grow into it. Obviously, the older the child is, where they've got less capacity or time to actually grow into their weight, i.e. they're adolescents and they're almost reached their adult height, that might be a different scenario. But really, on the whole, if they're just in the overweight or above the healthy weight category rather than well above, you would be just looking at weight maintenance. Another thing that we were asked was, when do you check thyroid function tests and look for a medical reason? Well, usually, I have to say, hypothyroidism is an uncommon cause of obesity in general in children. Most parents think it is the underlying cause, though, and quite often I add in TSH levels whilst I'm doing other bloods, just to be able to show the parents that this is normal. But you would certainly want to check thyroid function if there is a tailing off, crossing centiles of height gain, to suggest that there might be a thyroid problem. If they have a goiter, obviously you would want to check that too. If there is short stature, then you're much more likely to want to look for a medical reason. And other medical ones are if they have suggestions of Cushing's disease, so very violaceous striae, hypertension, they might be condition, or when you're examining them, the thought might go through that they might actually have some other underlying things. We've got a couple of other questions now, which was, could you repeat the age of which they should not be having a nighttime bottle? And really, I would say, if you've got a child at the age of 2 to 3, they really shouldn't be having nighttime bottles anymore, really. And it's not actually just for weight, it's actually also for dental care. And because if you go to sleep with a bottle in your mouth, much more likely to have dental caries, which is often a comorbidity that gets forgotten about. There's another one of what workup do you do at the first encounter, and subsequently looking for any genetic and medical things. So again, in pediatrics, we're very reluctant actually to do any investigations really at the end of the day, and there's got to be a good reason. So if the reasons that we would do investigations would be if they have severe obesity or weight status well above the healthy weight range, an older adolescent with obesity or severe obesity, if there's a very strong family background or from an ethnic background that have a higher risk of cardiometabolic issues, and when you examine the child or from history, there is suggestion of complications from their excess weight gain. So I would do bloods in that situation, and the bloods I would do would be fasting, and I would particularly look for iron studies because they often have iron deficiency anemia associated. I'd do vitamin D and vitamin B12 because vitamin D is often low and vitamin B12 can also be low, and it just acts as a baseline if you are going to start metformin. Metformin can interfere with vitamin B12 metabolism and reduce it even further. I also do liver function tests to see if there might be some fatty liver. I usually do a lipid workup as well. I personally, and us at Children's Hospital Westmead, we do fasting insulin and glucose. And as I said, I often just particularly on the first occasion, I'll chuck in thyroid function, just more to show the parents that in fact there isn't an underactive thyroid problem. So that's my usual sort of screen. I don't do liver ultrasounds up front. I'll only do them if they have particularly raised liver function tests 2 to 3 above the normal range, or there's persistence of raised ALT despite some weight loss. Because you've got to remember that raised AST, ALT, and is not always purely indicative of fatty liver.
So probably this is a good time then to go back to the website. And so this is actually a poster or a resource which is available under the Advise tab of that prohealthykids.newsouthwales.gov.au website. And it's actually a pretty good summary, which when we're in our general practice, when we're back in our practices, one of the team can run this through with a patient. So it's worth going through a few of the points here, because this is really about how to normalize eating and healthy behavior. So some of the key messages on the weight diagram, and this can be downloaded and given to patients as a handout. Eat together as a family at least once a day, and that's the be healthy together, that central message there. Drink water instead of soft drink, juice or cordial. Eat at least 5 serves of vegetables and 2 serves of fruit per day. There is a slight variation there for those who are slightly younger, but that's available on this slide, or rather available on this resource when you download it. Now, starting each day with a healthy breakfast, and there's been some interesting studies that show that the healthy breakfast does have an impact on performance at school. So that's another useful
angle for the parents.
Oh yes, for the parents. Say that your child's going to do better at school. Depends on the parent.
Yeah, true.
But yes, know your portion serve size. Now that's an interesting one, because I think that some of us as doctors sometimes aren't so good at that, especially when we go to some of these medical conferences and stuff. But well, we'll probably talk a little bit more about, or rather some of that information will be available further on when we look at the healthy shopping video. But choose healthier snacks and fewer treat foods, and limit screen time. Now this is actually a very interesting one, because while we do talk now about less than an hour a day for 2 to 5-year-olds and 2 hours a day for children 6 years and older, it's actually becoming increasingly problematic because schools are expecting so much screen time. And so sometimes we do have to talk about that in terms of recreational screen time as well. But certainly it's a message that we have to temper and we have to try to get out there. The 1 hour of healthy activity a day, and of course getting enough sleep, is another important part. So these provide a good sort of basis which can be used to allow the health providers to assist families to set goals for themselves. So a family can actually set a SMART goal on this. And now these are actually quite eminently suitable for setting SMART goals. So we will reduce our soft drink intake by this much by this point in time, and we will do whatever measurements to go and check that. Or we will attempt to have dinner together 5 days or 5 nights out of 7 because of whatever reason. So these are the sorts of changes which can involve the whole family and can help us to, well, create a more sustainable change.
And just to say that, you know, I know this, we've had some comments from colleagues about the fact that this resource is in English, and do we have the same one in other languages? And we don't at the moment, but we did, through the working party that we've got, that we meet regularly with a number of health professionals from different disciplines across different LHDs, we do have the translated versions now, sorry, but at the end of the day the main messages were through the pictures, and that it could be universal for anyone to look at these pictures. And as I said, we had a lot of to and froing and discussions, and we also sent off to experts within the eating disorder world to make sure that these messages were healthy messages for all. And just to say, to add on, there are actually smarter goals that you can have, and the E stands for emotion and the R is for reward, because E, most of the time we do things because of an emotional reason, not a logical reason. So again, maybe to tap into the reason to make some changes is to say, well, just think how much more energetic that you'd feel if you maybe lost a little bit of weight, or, you know, did these things rather than, you know, spending all your time or more time watching TV, for example. And to get behaviour recurrence, you got to reward yourself. So again, the reward has to be not around food and screen time, ideally, although sometimes it might be, you know, we suggest to families that the child can choose a sort of reward with discussion with the family, and that might be actually going out for a picnic with the family. And that means, family interaction, doing everything together. So as I said, a lot of work went into developing this, and at the end of the day, it's a great visual that you don't necessarily need to read the text, but get the messages from the pictures. And just one last one, someone gave a question: is there a reference for using metformin for kids to lose weight, and what's the dose and duration of use generally? So just in comment is to highlight that, as I'm sure you know, metformin is not a weight loss drug per se. It's an insulin sensitizing agent that sometimes helps when you've put in place lifestyle interventions to get some additional weight loss. And we do the same as what you do, I think, in adults, in that because of the GI side effects, we like to start at a small dose, and it's the same dose as the adults, 500 milligrams. I start off with that, and I work up to a gram after a couple of weeks if there's no side effects, and then eventually after another 2 to 4 weeks, lead up to 2 grams, and use the slower release preparation because I find that that gives you less side effects. And I do find sometimes when the metformin started, it does start a little bit of weight loss. And the other thing that I'm not sure whether you get the feedback from in adults, but we often get feedback from parents that the mood of the child improves greatly. It seems to be that insulin resistance makes you even more moody as a teenager, and if you treat the insulin resistance, they become much nicer teenagers. So there you go, that might be a positive. But as I said, metformin is almost like a last, not a last resort, but it's I don't start it readily. I like to try the interventions, lifestyle interventions first.
Yeah, so I mean that's a great reward actually if you get less moody adolescents in your household.
Oh, absolutely! Anything to work towards a positive outcome for everyone. It's got to be a win-win for everyone.
Oh yeah. So I mean, on that same page where this is found in the website, there's also some further resources on which can be used by the practice in terms of motivational interviewing and a module to work through on healthy weight and how to manage it. So moving on through the website, the next tab is on the assist part. So it's got a picture of me there. So here we go. So the assist part provides some videos which can actually be downloaded. And the video is, even though it's here for practitioners, is actually set up in such a way that it can be used by families and patients themselves. And of course, it's freely available on YouTube, and you can link to it on your practice websites and Facebook sites as well. So it's been done, it's been produced in order to be easy and in order to allow a patient who views it to have this in mind when they are going through a supermarket. So it's a literally aisle by aisle tour of the supermarket saying, do this, maybe that's not such a great idea. If that particular food is going to be in your basket, consider doing something else instead, and other ways of trying to manage the total calorie intake and trying to have a healthy intake. So other resources are able to be downloaded from this section, which is printouts which can be given to patients or emailed to patients, as well as other referral forms for secondary and tertiary services if we need to refer further on. So that probably brings us to the arrange part. And so in the arrange part of this, I'm going to pass on to Shirley, who can tell you a lot more about what other services are available.
So I think just realising that there many of the people that have signed in to the webinar are actually from New South Wales, but from those who are not from New South Wales, many of the states are actually doing a number of things to address childhood obesity. But this slide I'm going to talk specifically sort of about what's, and the next few slides actually that Ken's going to do is specifically on what's happening in New South Wales. And we are looking at a number of new services being developed within LHGs to help support families of children above a healthy weight. And so on the website we have referral forms, and also in the Children's Hospital at Westmead there is also an electronic form that people can click on to put in the details, and obviously the form gets electronically sent to the relevant people. So if you're not from New South Wales, I'm afraid I don't actually know specifically what's happening in your state, but I suspect there's a similar service that you can log into. But we'd certainly encourage you to have a look at that to do your electronic referrals.
So one of the big resources, especially since we're talking about childhood obesity, is the Go for Fun program. And so the Go for Fun program, for anyone who hasn't used it yet, is a very interesting program that we have been using quite extensively in our practice, and helps to provide extra bandwidth in managing patients, because managing weight in both adults and in children is a very time-consuming process, and it's something which, even though it may not be classified as chronic disease, has to be managed using the same chronic disease model. So basically, if we don't manage it, it will recur. There will be relapses, there will be remissions, and so we've got to go through the same processes. So Go for Fun is a free community-based child obesity treatment program. It's quite structured. There's a once-a-week session, which is delivered during the school term, but over a school term. And the child will go into the program, sometimes with their siblings, always with a carer or family member. And while the child is involved in activities and some educational things, the parents are involved in further education as well. So it actually educates both children and their parents. So here's the eligibility criteria, which is that unfortunately it's only in New South Wales. Unfortunately, it's only for 7 to 13 years, and in general the programs are done in such a way that they'll group children of a similar age together. So you won't get 7-year-olds in the same program as a 13-year-old generally, although if the program is there, there'll be separate groups of 7-year-olds, separate groups for other older children. So the program outcomes are listed on this slide here. But the bottom line is that there have been significant improvements with this, and there are, interesting enough, some of those other components that Shirley talked about, such as those reward systems, which are used in this. So where a family is able to make changes to their lifestyle overall, the family actually has some reward, and there is excellent feedback for this. Now, some of the other points are that 74% of the programs have been delivered in the socio-economically disadvantaged community, 28% of families have been from rural or regional communities, and there's a specific Aboriginal Go for Fun piloted from this year. So it's something that anyone can refer to, and they can refer from this website. And to let you all know, there's even pre-populated templates available in Medical Director and Best Practice to make it easier to refer patients to this service. So if you look under the supply templates in either of those programs, you'll find you'll be able to have a sheet like you see on the screen here, download it and get ready for the patients to, or rather for you to fax off for our patients. The other service, which I think also answers one of the questions raised here about any telehealth resources, is actually the Get Healthy service. And so the Get Healthy service is actually more for adults, but 16 and over, and the service requirements and the service facilities are listed here on this slide in bullet form. So probably again, there's no need to go through each of these in detail. However, few points to pick out. There have been significant improvements. While there's a mention here of Get Healthy in pregnancy, the Get Healthy coaching service is, as opposed to Go for Fun, which is a group program, Get Healthy is an individual telephone coaching service. And with this individual service, you can specify on the referral forms whether a patient is referred for a specific reason. So, for example, diabetes, hypertension, gestational diabetes, pre-diabetes, whether there's any other specific issues. Fatty liver disease and alcohol actually are on the list as well. And this assists the telephone counsellors to be able to tailor the program more specifically for those who are there. Now, there is this question about what do we do with 15 and 16-year-olds, and the answer is very good question, because that might come down to a question which needs which actually needs a much broader question, which is a much broader question, which is what do we do with adolescents overall? Because that is a different group which may require a slightly different approach. But we'll leave that to some of the scenarios which are coming up, because we do have scenarios where we discuss about what to do with adolescents, because it is true. Different age groups do require different approaches. The drivers and the levers for each group are different. So we might move on now to the scenarios, as I realize that we've been talking a lot, and we're going to miss out on these scenarios unless we move on to that. So the first one here is some of those issues that are managing motivation and expectations. So Shirley, shall we both talk to these ones? I'll let you start off first.
So you might get the situation where the family believes that either they're doing everything or there's nothing additional that they can do. And again, I think there's always something that can be done, and just trying to tap into one area, even if it's just asking them, well, are you drinking water as your main drink? And having just half a glass of orange juice every day. Are you going for a walk for 10 or 15 minutes every day just to get moving? Are you sitting together as a family for your evening meal? You'll probably find that there'll be something that you can focus on in the 8 for a Healthy Weight, that there'll be something there that they can actually do. And even if at that point in time they still think there's nothing, I think Ken's already said, you can give them the resource to say, okay, maybe at this point in time we can't think of anything. Take this away with you, have a think about it, and then we can talk about it the next time you come back.
Yeah, so it's one of those things where, again, there's it does take a lot of time. It can be very time consuming. And what's interesting is that it's not always necessary to target the child with Go for Fun, because it's frequently still going to be an issue with the family as well. So the issue of overweight is likely to be an issue. Statistically in our practice in Mount Druitt, where we have weighed 87% of all our patients, and of that 87% of patients we've weighed, the level of overweight and obesity is between 80 to 90%, depending on the age group and particular decile. So we can still use the Get Healthy program to assist for that. And certainly that 8 for a Healthy Weight is actually a very useful resource, because it's almost like a menu. You can say to the family, pick which one of these do you want to start with first, and let's review the situation after that. And I think that sort of brings us to that second point, which is what should I do if a patient's family say if they tried everything without success. And one of them is actually going through that 8 for a Healthy Weight, and it provides a very good scaffold in terms of how do we use the 8 for a Healthy Weight as a scaffold in our day-to-day practice, which is that it literally can be bullet points and say, have we tried this? What has been done here? What's been done here? What can we do to improve that there? And there are, of course, the other resources, which is where we can refer to other services as necessary.
Yeah, and I think sometimes what I like to say is, look, you may not think you've had success in trying these things, but actually what the studies show is if you've had no intervention or tried nothing, then the weight gain would probably have been even more. And so think in terms of that, in fact, you've probably made a difference, you just don't realise it. And even if you don't see a difference, and again, this is not to focus on the weight per se, but if the child has become more active, they're more likely to be healthier and have less complications from the excess weight gain. So I think to convey messages of positiveness, and that, it's great that you've tried some things. It may not have made as big a difference in the weight gain, but they've maybe got a bit fitter, or they're managing to concentrate more or sleep better. And often I think sleep's a sort of that forgotten cousin that, you might not have made changes around the sleep that you can maybe focus on. So I think there's always something that you can sort of work on around that. So I would, as I said, say that if you hadn't done anything, the weight gain would potentially have been actually greater, and so you have made some difference, you just don't know it yet. So just keep going.
Yeah, and it's a good point that unfortunately one of the traps I fall into in my practice, Shirley, is that I think that I often tell patients, well, you haven't lost weight yet. Oh no, you put it on again. And that can be a big issue because it's really a great demotivator if I keep saying the same thing. So at some point we've got to find something positive to work with. So the next slide is really about the issue of managing beliefs. So how do we manage different beliefs within the families? And this can be a very tricky issue, certainly, and certainly we find that. And maybe that given that we're running low on time, we might try to deal with all of these in one sort of big block.
Yeah. So I mean, I think. Again, I think for me, I find it's a bit like the customer's always right in the sense that don't. I like to aim for the positive and say, look, you know, you are where you are because of the knowledge that you've had or the resources that you've had. You've been doing your best. I'm here to help you do even better and make some changes around some of the things that might be stopping you make some changes. And they might be around the beliefs and that, you know, the only thing that you can do is use food or use screen time for reward, and get them to think outside the box that actually at the end of the day, you know, you can use stickers, you can use, time. Children want to spend time with their parents, and often we don't spend enough time. So it's just little things like that you can sort of delve into a little bit. And again, it doesn't actually have to take too much time to find out where asking them, what do you think might make the changes? What do you think, is stopping you from making changes? And also one of the main ones that we have is the sort of, it's cultural to be big, and that's the desirable trait. And again, it's like, well, I understand that, and that's fine. And maybe, we're not looking at major weight loss, but just to take the edge off some of the complications that might be happening because of that excess weight gain. It's not to say, this is right, this is wrong. It's let's work within what you know, what you believe, what we know as health professionals, and what we can do to optimize the health for everybody. At the end of the day, it's about health, not specifically weight per se, but optimizing health so that you can do what you want to do in your life.
Yeah, and so it comes back to the principles of motivational interviewing, which is how do we define what is meaningful for any family, for any child, for any parents, and then we work with what we have. So I think a lot of these issues have been, a lot of those questions in this bullet, in this slide have been covered in this and the previous, in our discussion. So we probably should move on to this interesting and challenging issue, which is managing adolescents. And because we know that adolescents have different drivers. So, for example, one thing we found in our SALSA program, which is the Students as Lifestyle Activists program, which is a child obesity program in schools, is that adolescents are the people adolescents listen to most are not their parents, not their teachers, but actually more their peers. And so one of the approaches we therefore have to do is find how do we approach adolescents, how do we try to get that change. Sometimes it is about trying to find the right peer group, sometimes it's about trying to work out what is important to the adolescent and what are the drivers for them.
Yeah, I would totally agree. I mean, I think the way we often work, and it seems to be working well with adolescents, is it's still family-wide changes, but it's actually focusing on the adolescent and aiming to get them engaged and give them some accountability and choice and responsibility so that the adolescent makes the decision about what changes they want to make and the parents support that decision. And we've found that actually works really, really well.
Great. So some of the questions that have come up here about Will talking about weight cause and eating disorder. Yeah. Shirley, have you ever found that?
So no, we've never found that, I have to say. There is no evidence to say that dealing with or doing weight management in a supervised way triggers an eating disorder. We aim for teaching and giving strategies around healthy weight loss if that's needed, and it's basically looking at healthy lifestyle practices that can be sustained. It's not about being on strict diets and sort of depriving yourself of foods and things. It's about having a healthy attitude towards what you're eating and your activity. So as I said, even in children that we've seen quite marked weight loss, as soon as they stop seeing us quite so regularly, the weight starts to go back on again. So we have no concerns about good advice around weight management triggers an eating disorder.
And I think that really comes back to where we consider weight issues as a chronic illness, and that is that whether it is or isn't classified as one, it is all about that follow-up. It's the fact that if you stop taking your antihypertensives, often the blood pressure will go back up. Same with weight. Stop doing the right thing, then there will be relapses. But just like all, if there's relapses, well, we're trying to be there to try to help with the remissions.
Yeah.
So this is probably, as we're now running very short on time, where we need to talk about what's coming up next. So the next webinar is the Go for Fun program, much more specifically. And that's on the 18th of October, same time, same place, with Dr. Georgia Regas and Shirley. And again, this can be, you can register through the RACGP website for this seminar. So again, another very interesting and useful seminar coming up. So there is also the option to have more webinars next year. So any feedback, there are 2 more webinars planned for early next year, but any suggestions that you'd like us to cover, please send them in, and we'd be very keen to see what would be of interest to you, to all of the general practitioners, to all of our colleagues, and I'm going to say to our extended practice teams as we work more and more in a team-based environment. And the GP17 active learning module. So on Wednesday, the 25th of October, so on Wednesday of the GP17, between those hours, there will be the active learning module, which will be run. I think, Shirley, you'll be there.
I'll be there along with some other colleagues.
So we'll all be there to talk further about this issue. And so anyone who's going to be along there, again, you can register through this through the website, which is on the screen in front of you. And now that brings us to the formal end of what we're talking about, and we're open to any questions which might arise.
So I think there have been some questions in particular about parents that are separated and involving child protection services, and that's a topic close to my heart, having written a paper on it, but I think that's a sort of topic that actually has to be discussed in much greater detail, and we don't quite have the time at the moment, and I think we'll either reply by email or maybe cover it in some of the other webinars. I think one is, how do you approach parents who believe the issues of solely genetic or being big boned, or that their weight of the baby is appropriate? I have to say, I tend to say to everybody, look, we all have a genetic propensity to put on weight, some more than others, and so we've all got to work at it. Most of us do have to work at it, and there's no real such thing as big boned, and really at the end of the day, again, we're looking at being healthy. It's about being healthy, having energy, feeling good about yourself, being able to do things, and when you have excess weight gain, that often restricts what you can do. So it's really looking about health and talking about how to, optimize what you want to do in life. Do we continue? Yeah?
If there's a few more questions.
If there are a few more questions.
Go for it.
At what point does the child will need intervention like medication and surgery? So, as I said, medication we use very, very rarely at the moment in children. We will use metformin for those that have marked insulin resistance, and by that that's often you have marked acanthosis nigricans, which again you'll see in adults. And if there's a strong family history and they're an adolescent and they're in the severe obesity or way well above the healthy weight range, and they've got complications secondary to their obesity, I would consider metformin as an insulin sensitizing agent in conjunction with lifestyle interventions. Have to have lifestyle interventions. Surgery, unfortunately, another topic that we could talk all night on. I think there are some children, again, they need to be post-pubertal, having reached their maximum sort of adult height. So usually around the age of 15, 16, you might consider surgery in those, again, well above the healthy weight range or severe obesity, strong family history of type 2 diabetes and obesity-related issues, and have obesity complications. Now, unfortunately, at the moment in New South Wales, anyway, there is no real public money available for adolescents with severe obesity for bariatric surgery. They're usually lower down on the list. It's usually adults with multiple complications that get bariatric surgery ahead of an adolescent. And that, again, is another topic in itself that could be discussed. For most adolescents, if they're going to go for bariatric surgery, it's often done in the private sector. The only thing is that really the adolescents that probably need it more are the adolescents from the lower socioeconomic sector and can't actually afford the bariatric surgery. So, as I said, it's a controversial topic, but there are some working groups, particularly within New South Wales, that are looking at how we can provide services, including bariatric surgery, for those adolescents that specifically need it.
That brings us to the end of this evening's webinar. Thank you again, Shirley and Kean-Seng, for joining us. If you feel you haven't had any of your questions answered, please feel free to send us through an email. We'll be happy to get back to you. And just before we go, I would just like to remind you that this is a QI and CPD activity. So if you can please complete the evaluation that will come up at the end of this session, we'd really appreciate it. And we hope you found tonight's session really useful. Thanks for joining us.